A very good morning to everyone watching us on Rest TV. It's a Wednesday and we get to have a health talk on the diagnosis. My name is Kasule Fionalin, and we're having a continuation from last week. We left off when we were asking the doctor, is it possible for us to store our eggs somewhere and use them later in the future if we want to have children? And yeah, he's going to answer that as we get into our conversation. We're still dealing with the topic of infertility. Today we're going to be mainly looking at infertility in men, and then we'll also look at the treatment options that are available in Uganda for us. You're very welcome, Dr. Muhumu Muza Joseph.
Thank you.
How are you doing?
I'm all right. How are you doing?
I am well. Yes, last week we kicked off, we went off when we were asking if there is a way we can store our eggs and finish up with our careers and have children later in the future.
Yes, that is very possible. There is what we call cryopreservation. It's for both the male gametes, the sperms, and also the ovaries, the eggs. So that is very possible. It's useful for these people who are still chasing their careers and they want to have their children later on. And also these young people who are undergoing chemotherapy, let's say cancer treatment. Because cancer, we know cancer treatment normally affects the gametes, so they also benefit from that. Yes.
Okay. Infertility in men. Last week we said so much about the women, and we got to understand that we share an equal percentage.
Yes.
35 men and women in the infertility.
Yes.
Now today we are looking at the men.
Yes. The men take still the 35% of the infertile couples, of the causes of the infertile couples.
Yeah.
So in a man, to look at infertility in a man, the definition stays the same.
Yes.
We still define it as failure to conceive after 12 months, which is 1 year, of unprotected regular coitus. Investigation may come in earlier, let's say if the woman is above 35 years. Like I said there, we may not wait for 1 year. Within 6 months, we normally start investigating this couple. So to look at infertility in men, you need to know what does the man do during the process of conceiving and getting a baby. So what a man needs to do is really to produce mature and concentrated sperms.
Mature and concentrated sperms.
Yes. And be able to transport these sperms from his ducts up to the woman. I'm talking of ducts because the male, as we shall see along, the male reproductive system has ducts, a lot of ducts, which are involved in the production of these sperms and their transport. So a man needs to produce enough sperms and be able to transport these sperms up to the woman. That's his role. Yes. So any disturbance along those lines will lead to infertility in a man. Yes. Basically, because there are so many causes in men, but to simplify it, the way we classified the causes in the women, we started with the ovaries, we went to the tubes, we went to the uterus, then we went to the cervix.
Yes.
So to start with the man, I will classify it along those lines so to make it easier for the people to understand. So among the causes, we classify them as they are what we call the pretesticular. Those are the causes which have nothing to do with the testicles. Because we know the testicles are the ones which produce the sperms. And then we have the ones to do with the testicles themselves. So those ones we call them the testicular. And then we have the causes which are after the testicles. So those we call them the post-testicular. Yes. So pretesticular, it means the problem is not with the testicles. It's not really with the synthesis and production of sperms. It is somewhere else. And what we know is the male function is not only limited to the down part. It starts away from the brain. Yes. So the brain normally sends a signal by production of some hormones which will initiate the production of sperms in the man. But if this signal is interrupted, then the production doesn't happen.
Okay.
So the pre-testicular usually are to do with factors which are a little bit above, and mostly it is the brain or hormones involved.
Okay, so do men also suffer hormonal imbalances?
Yes.
Okay.
Men have hormonal imbalances, just like the women. So the most common causes on that side, we have what we call the Kalaman syndrome. That is a defect in the production of some hormone which normally triggers signals for sperm production.
Okay.
That hormone comes from the brain. So mostly these people present with maybe a loss of sense of smell. Yes. The other common condition is it is what we call hyperprolactinemia. You've seen a few men with not just big breasts, but sometimes these breasts also produce milk.
Yes.
Just like a woman. Yes. So hyperprolactinemia, there is an abnormality in that hormone prolactin in a man. So that also interferes with sperm production.
Oh, okay.
Yes. So those are the most common causes before we reach
can you detect that abnormality when a child is still way young?
Way young, you may not detect it unless there's what we call precocious puberty. Precocious puberty, this is where the child is getting these what we call the secondary characteristics, pubic hair and what, before the age of 9 years.
Okay.
So if that would be the first indicator that something could be going wrong.
Okay.
Yes. So when we move to the testicular causes themselves, those ones are quite many. The common causes, there's what we call varicocele in men. You see, the testes are located outside for some reason. The reason is to give the required temperature for sperm production.
Okay.
Yes. But when someone has varicoceles, these are swollen blood vessels within the testis. So those blood vessels tend to keep a lot of blood in there. And with a lot of blood comes with a lot of heat. So the temperature becomes unfavorable for sperm production.
Okay.
Yes. So most of people with varicoceles, you find they have no sperms. That's the most common cause. The other common cause is infections.
Still like in the women?
Still like in the women. This time the infections are specific. There's what we call mumps.
Okay.
Mumps otitis. It's a viral infection. Normally it starts with swelling of there's what we call the parotid gland. It's just located here. So there's that swelling.
Okay.
And then this virus normally also goes down and infects the testis. So usually those men also have problems. Then the other cause is there's what we call cryptorchidism. Initially, when a man is developing, the testes are located up there in the abdominal cavity. But they have to descend down the scrotum before birth. So in some individuals, you find either one of the testes didn't descend or both of them didn't descend. You find the scrotum is empty. Yes. So that can be corrected in early life. The testes can be brought down. But if it is not corrected and these testes stay up in the abdominal cavity, that environment alone is not favorable.
So it becomes a permanent defect?
Yes. It's not favorable for production of sperms. Also very common. It's not a textbook thing. It's common and it happens.
Okay.
The other common cause is trauma, where you find there's an injury to the testis. Let me say someone hits you down there, or you get a motor accident and something hits you down there. Because what we should understand is where the testes are made from, that place is free of blood.
There's no blood.
It's like the brain. There's what we call the testicular blood barrier. There's a barrier. So blood shouldn't go there.
Okay.
So if there is, let's say, an injury and blood enters that place, then there's a problem with production of sperms.
Okay.
Yeah, so that can happen, let's say, through an accident or someone hits you by accident. And then there are also men who produce antibodies against their sperms. This could also be a result of the injury which someone suffered.
Oh.
And then these sperms found their way in the bloodstream and antibodies were produced. So you'll be producing sperms, but the antibodies are killing these sperms. Yes. Then the other cause, I'm looking at the most common causes, is surgery. Let's say surgery was done on you, and maybe you had a hernia or you had a hydrocele, especially this what we call the inguinal hernias, femoral. Because one of the ducts that transports the sperms or actually passes also along that region. So let's say in the process of hernia repair, one of those ducts was mistakenly cut or even tied. Yes. So that would make sperm transport very difficult. You'll be producing sperms, but these sperms will have nowhere to pass. Yes.
Doesn't it cause a problem?
It doesn't cause a problem, because if it did cause a problem, then vasectomy would cause a problem.
Oh, okay.
Yes. So those tubes, there's what we call vasectomy, where we tie them, where someone is sure that they are finished with childbearing, then we tie the tubes, just like we do for the women.
Okay.
It can be reversed, but the success of reversal is small.
Oh.
Yes. Okay. So before usually it is done, someone has to be quite sure that they are done with production. Yes. So those are really the most common causes. The others are maybe someone is undergoing chemotherapy, like I said, they have cancer, they're undergoing chemotherapy. Chemotherapy affects sperm production. The other risk factors are these diseases which affect us as men and give us sexual dysfunction in form of maybe erectile dysfunction. The common ones is diabetes.
Okay.
Yes, diabetes and hypertension. Then also the life habits. Smoking is not friendly
to men.
With sperm production, especially if it is chronic smoking. Yes, so also that one comes in. Yes, so those are the most common causes we look at in the men. Yes.
So when a man comes to a hospital, given all these factors, what kind of tests do you run? Unlike the women, you do the scan and all that. Yes. So what kind of tests do you run on the men to rule out cases of infertility or something?
So for the men, the good thing is our tests are not really wide. Although the men fear hospitals, but we don't have a wide range of investigations for the men. Usually it is simple. 70% will come in, and from their history, from what they tell you, even before running any tests, you will have an idea what is causing their problem. So he will come in, obviously you will evaluate the age, you will screen for all
Actually, let me ask,
yes.
just a moment. With men, is age an issue like women?
Age is an issue, but not as much.
Like with the women?
Yes, not as much as women.
Okay.
It is so limited. The effect is limited. But we still look at it. So a man comes in, you look at the age, you look at his habits. Is he a smoker? Is he what? Then you look at his also sexual relations. His previous relations, has had children with other women, maybe his past relationships. Is he a smoker? Has he had a history of surgery, a hernia surgery? Where he works, is he at a risk of exposure, maybe to, let's say, X-rays or radiation, which could affect sperm production? You look at the way he looks, because some conditions are quite clear. You look at the body and you say this is clear an abnormality. Then you'll go ahead and examine. Start from all the head down. If it is hyperprolactinemia, as I said, the breasts will be big. Then you go down and examine the genitals. are the testes the same size? Are they all down there? And then you also look at the sexual organs. How is the size? Are they small? Is the urethra located where it is supposed to be? Because there is what we call hypospadias, where you find the urethra, instead of being on what we call the dorsal aspect, is a little bit down.
Okay.
So that will cause problems with the deposition of sperms in the woman's tract. So all those you examine. And usually from that, 70% you're able to tell. It's just the others that maybe you may need to go ahead and do a few investigations. Yes. And the common investigations we do, there's what we call semen analysis, where we check your sperms. So we normally want an abstinence period of about 2 to 3 days. Because if the abstinence period is short, it may give us wrong results.
Okay.
If it is long, still it may give us wrong results.
So you want average?
So we want average 2 to 3 days. And most of the time, that gives us the answer for the men. A few, we need to do a few hormones here and there.
Okay.
Yes.
Do you also give them contraceptives as a hormonal treatment?
No.
Why?
No, we don't give it, because their hormones are, okay, so we share some of the hormones with the women, like the LH and FSH. And then the other main hormone for us, the men, is testosterone. So the contraceptives normally have progesterone, estrogen, which for us as men are not really our primary hormones. So they don't really affect our axis that much.
Okay.
Yes.
So in Uganda, okay, we've seen the tests are being done. What is a possible treatment plan would you give? 1 to a woman, 2 to a man, then as a couple?
Okay.
Because at times maybe treatment is maybe meant for the woman alone or for the man alone or jointly as a couple.
Okay. So, because usually this fertility treatment, like I said in the first instance, it's a couple treatment. So if you look at the woman and the woman is fine, and maybe the problem is with the man. Now the problem with the man, how you treat it, depends really on the extent of how low the sperm count is. Because the sperm count can be slightly low, low, or very low, or completely absent. Like there is no sperm at all, zero. It's called azoospermia. Or you could have sperm, but the sperm is deformed. You find the tails are 2, the heads are 2, the DNA is deformed.
Yeah, actually, you talked about having a good quality.
Yes, good quality, mature
concentrated sperms.
Yes. Yes.
So how do you determine that this is good quality? What concentration are you looking for?
Yes. So during this semen analysis, we look at so many things. The first thing we look at is the volume. How much semen has he produced? Normally want about 1.5 to about 3 mils of what the man produces. So what I was telling you is that if the abstinence period is short, this man is going to give you a low semen volume. And you may think it is abnormal. If the abstinence period is long, the semen volume goes up, and we think it is also too much now. So volume comes first. Then you look at the concentration of sperms in each meal of that volume. If he has given you 3 meals, that 1 meal, how much sperm does it have? The normal is about 20 million and above. 20 million sperms per 1 meal like this. There are usually so many. That's the normal. Then of these sperms, you have to see which ones are moving. And with purposeful movement. The movement we are looking at is forward movement, progressive movement. Not these ones which go side to side and back to back. All these ones which swing in circles. So we want forward purposeful movement.
That is how you determine a healthy.
Yes. So you see of what he has given you, which percentage is moving forward. Yes. And then of still the ones he has given you, which percentage is alive? Because there's dead sperm. Everyone produces dead sperm. But which percentage is dead and which one is alive?
Okay.
Then you also look at the what we call the viability, like how good this sperm is. And then you also check for infection. Still within the sperm. Because if there is infection, you're able to see from the semen that he produces. You will see what we call leukocytes in the sperms.
Okay.
If it is more than 1 to the times 10 to the power 6, then that is a little bit significant. Then that will tell you that maybe this gentleman is having an infection in the testis, which we call otitis, that could be interfering with the sperm production.
Okay.
So semen analysis gives us almost everything, and it grades you. How low is the count? Is it low, very low, or just low? Or is it completely absent? Or it is normal, but most of these sperms are abnormal. 2 tails, 2 heads, movement is poor, and all those things. Yes.
Okay. Now, treatment plan. Like you've said, we deal with a couple.
Yes.
What treatment plans are there?
So the treatment plans really, like I said, especially when we are looking at the male factor, it depends on how much sperm do we have. Because treatment has gone forward, it has like evolved that we are able to achieve a pregnancy with just 1 sperm and 1 egg. Sometimes you may not need all these millions and millions of sperms. The millions and millions are needed if we are looking at natural conception.
Okay.
Because what you have to know as a couple is sometimes immediately after interaction, most of what the man deposits comes out. Most of the the ladies will feel it. 70% of what the man puts there comes out. It's the 30% that goes in. And that is just at the cervix. So that 30% has to find a way to move from the cervix, past the uterus of the woman, and reach the tubes where fertilization happens. So that's where we want that within that 30%, at least we should be having enough millions of sperm
that are
to
healthy,
be able to reach up there and achieve a pregnancy. So that's where the millions and millions become helpful. But if it is not natural conception, the millions become irrelevant, because we can achieve a pregnancy with just 1 sperm and 1 egg.
What is the lifespan of a sperm?
Well, the lifespan it really varies. It can go up to 3 days. So even this intimacy before the actual day of ovulation could result in a pregnancy. Yeah. So that's what we call timed sexual intercourse. With timed sexual intercourse, what we do is we monitor this woman's cycle from day 1. We see how her egg grows. When it reaches the time of ovulation, we trigger it so that she actually ovulates.
Okay, on that day?
On the day of when it is mature.
When it's mature?
Yes. So after trigger, most of the time ovulation happens within 24 to 36 hours. So that's where we tell the couple to be a little bit active. And most of the time where you find, let's say the cause of infertility is unexplained, or the couple is normal. You've investigated all of them, and you can't really see the cause. You do timed sexual intercourse and you find most of them are conceiving without all these other aggressive interventions.
Okay.
Yes.
Okay, we are going into a break, and when we return, we are going to be taking calls and talking more about treatment plans for infertility in Uganda. Welcome back from that short break. Before we went into the break, we were talking about treatment plans on infertility in Uganda, those that we have in Uganda, and we are going to be looking at more of those and even the costs, and it's up to you to know whether you want to do it or not to do it, or whichever way, but we are ready to take your calls. You can please call in, ask your questions that you need to ask about infertility. Because, I mean, you could sit back there and it's simply because you're ignorant about something and you're suffering. So please make your calls and ask your questions. Doctor,
Yes.
we're looking at the treatment plans.
Yes. So the treatment plans, we look at it still as a couple. There are those couples which you will really help to conceive naturally. But there are those where you will find it impossible for them to conceive naturally. The impossibles are those where you find either the sperm count is very, very low or it is completely absent.
Okay.
That is on the side of the man. On the side of the woman, that's where you find the tubes are completely blocked. Completely blocked, and they cannot be salvaged. Because there is some treatment we do for the tubes.
Okay.
But there are those which you can't really salvage. So in such a couple, you find natural conception is a little bit hard. So we do the other way, what we call the artificial. And the artificial, we have so many options.
Okay.
It's in short called IVF, in vitro fertilization. Because with in vitro fertilization, you don't need the tubes. You don't need these millions and millions of sperms. Everything is bypassed.
Okay.
So that is IVF. So IVF, what we do is we take over the woman's cycle. So we stimulate her so that she grows a good number of eggs. Let's say about 12 or 14.
Okay.
So we monitor these eggs through the cycle. Once the eggs are ready, we harvest them. After harvesting them, that's the day the man will give us his sample. Yes. After giving us his sample, we screen it, the man's sample.
Okay.
And of all those millions of sperms maybe he has produced, maybe 2 million, we shall just need 14 sperms, because that's the number of eggs the woman gave us.
Okay.
So we get each individual sperm and fertilize it in each individual egg. There's an illustration we are going to see. It's a video. So we are able to pick one sperm, fertilize one egg. So we fertilize all these eggs that we harvested. So after fertilization, that's what we are seeing on the screen. So the round thing there is the egg.
Okay.
That's how it looks. And then that small needle in it has a sperm which you can see moving.
Yes.
So as it comes close to the egg, the needle will pierce that membrane and enter. So once it enters, the sperm will get sucked inside the egg, and then you will be able to retract your needle. So you can see the sperm is coming back. As the needle comes out, the sperm goes in front.
Yeah.
So that is fertilization. It is called intracytoplasmic sperm injection.
Okay.
Yes. So there we don't need all these millions. So after we fertilize that egg, we incubate it.
Okay.
We incubate it and put it in an incubator, an artificial womb. It will grow for about 3 to 4 days. Actually 3 to 5 days.
It undergoes that process?
Yes. It starts developing. It's now a baby. So on the 3rd day we come and check all these 14 eggs that we fertilized. How many babies did we get? And what is the quality of these babies? So we choose the best, maybe about 3, depending on what the couple wants. And we get those and implant in a woman. We put in the womb. Then usually 12 days after we've implanted, 14 days, this couple will come back and we check for pregnancy. So that is IVF in short.
Okay.
But we don't throw the other embryos that were fertilized.
You leave them in an incubator?
We keep them. We preserve them. The way we preserve eggs, the way we preserve sperms. So we keep them, because this couple may still not conceive
again
with
naturally.
this IVF. So instead of repeating the whole cycle, you go back to what you kept,
and
pick your embryos and come and re-implant.
Now, the process of keeping them,
Yes.
have they paused in their growth and waiting to be implanted to continue growing, or are they
Yes.
growing?
They pause in their growth.
Okay.
We make them sleep, and then when we want them back,
You
we
wake
have
them
to
up.
wake them up again. So in that case, you see the quality on how the embryo wakes up. You will see how it wakes up and how it progresses before you transfer it
Okay.
again into the woman. So that is IVF in short. That is for couples where you find really the factors you cannot treat them. The tubes are completely gone. You can't salvage them.
Can you stimulate more eggs and fertilize more eggs and keep them, just that in case after giving birth they can still come back and reuse?
Yes, it is very possible.
Okay.
We can, because there are these couples who are in their evening years, especially on the woman's side. She's planning to have her first child on 39 years. And you've already checked the ovarian reserve is low. So you cannot have this time of allowing her to first carry this pregnancy, and then she comes in later, you repeat the process of IVF. So in that case, it is safer. First stimulate her over, let's say, 3 cycles, get enough eggs, keep some of them, then fertilize some, which you can use in this cycle.
Okay.
So that by the time she comes back for other pregnancy, you have something there. Yes.
Okay. Which other treatment plan is there?
So IVF is like the deal breaker, because it will treat all the causes of infertility. Whether the man has 1 sperm, all the tubes are completely blocked, all what, IVF will treat it. Yes. So there are simpler interventions which are not IVF. There's what we call intrauterine insemination. Intrauterine insemination, this is a couple which you've investigated. You find the woman is okay, maybe her only problem is she's not ovulating, and her tubes are completely open. You investigate the man, he's completely okay. Okay, maybe the sperm is a little bit on the lower side, but not very, very low. So this is a couple which will benefit from intrauterine insemination.
Okay.
So in this case, what we do is we stimulate the woman, just like we did in IVF, but not aggressive. Because we don't need all the 11 eggs or the 12 eggs. With insemination, we need just about 3,
Okay.
or maybe 4. So we stimulate her, we watch these eggs grow. Now when they are ready, the man gives us his sperms. So we wash them and then concentrate them. And then instead of them meeting, we get these sperms and deposit them directly in her womb.
Okay.
So these sperms will move from the womb and go to the tube to look for the egg. And fertilization will happen there. Yes. So that is intrauterine insemination. It is a bit cheaper compared to IVF, because IVF is really still a very costly adventure. Yes.
Okay. Then which other options do we have besides the IVF and the intrauterine conception?
Okay. So IVF also has its own categories. There's category 1, where the man and woman are maybe young. The problem is just maybe the tubes or a low sperm count. There's category 2, where the woman is okay and the man is completely off. There's nothing. If the tubes were tied, we shall see fluid, but in that fluid there will be no sperms.
No sperm.
There will be no sperms. So when we find no sperms, we go ahead and check his hormones, LH and FSH. Because these tell us if the testis is actually producing the sperms and these sperms are blocked, what we call obstructive, or if the testes are not producing anything. Yes. So if the hormones are okay, then we shall know these sperms are being produced, but they are just blocked somewhere. Maybe this tube was actually cut. So that's where we start looking at processes of reversal.
Okay.
Yes. But to start with, let him do a semen analysis.
Okay.
Yes.
With the men, is it also possible that their sperm cannot move up, or their sperm is stagnant or something like that?
Yes. So the compatibility, we looked at it in form of a woman's mucus killing the man's sperms. That is one way. The other compatibility for a men with movement, like I said, these sperms need to have purposeful forward movement. That's what we want. The other sideways, running around in circles, that one doesn't achieve a pregnancy. It's purposeful forward movement. From the woman's
Then there's also an issue, doctor, of there's a time you talked about the quality of an egg.
Yes.
That can either determine the quality of the child that is born.
Yes.
You talked about children that have the Down syndrome and all that.
Yes.
Does the quality of the sperm matter as well? That can it also cause such effects?
Yes, the quality of the sperm matters, because the sperm's DNA is also important. Then within the sperm, there's what we call a centriole. So once the sperm enters the woman's egg, to put its DNA, and also this centriole is needed, because the fertilized egg will need 2 centrioles for it to start dividing.
Okay.
Because the fertilized egg has to divide from 1 cell to 2 to 4 to 8 to 16 to 32, like that. So if there is a problem with the quality of this sperm, still division will not happen. Yes. So also the quality matters.
Okay.
Yes, because even with the artificial fertilization we saw, if the sperm's quality is poor, you will still inject it inside the egg, and you will find that that embryo hasn't actually progressed.
Okay.
Yes. So quality
Matters.
is both sides.
Okay.
Yes.
Finally, in Uganda, we're talking about the bank where you store and all that. Is it affordable?
Well, the truth is, infertility, which involves artificial means, especially IVF, is still costly. Not just in Uganda,
But everywhere
even
else.
outside countries, it is still costly. So most of the couples find that financial burden a little bit too much. But some of them, you find there's really no other option. Because fertility, a cycle alone, if it is a simple cycle, the man is okay, there are no other bad factors, it may cost you between 16 to 22 million.
Wow.
Depending on where you do it. If it is a complicated cycle that involves someone donating to you an egg, let's say in an older woman, or the man has no sperms at all, and he needs a donor, that one the cost goes a little bit up. It can stretch up to 26. Then there are these couples where you find the couple can't carry their own child. There is what we call surrogacy. Someone has to carry for them. That one becomes more costly because the surrogate has to be paid. Has to be paid and has to be insured medically because she's carrying a pregnancy. Pregnancy comes with risks. She may get high blood pressure of pregnancy. You can't know how the pregnancy grows. So surrogacy, once it comes in, it also makes the cost a little bit costly. So infertility, once it involves IVF, is expensive. That is the fact. But what we normally aim at is leaving out IVF. Try to handle this couple with these, treat the reversible causes and get this couple to conceive. It's only when you're left with no choice that we move to IVF.
IVF.
Yes.
Okay, in closing remarks, what do you advise people to naturally do away from infertility if there is, like the smoking, all those kinds of things?
Well, for the men, it's healthy habits. Smoking really affects our sperms. if you can do away with it, affects it actually much more than the alcohol. So if you can do away with the smoking, the better. Then the way we take care of our downer part, these are the tight panties really. They don't give us a conducive environment down there. You don't have to hold things tight. Put on the loose ones. Yes. And then any small pain, especially down there in the scrotal area, even if it comes and goes, have it investigated. Because there's what we call testicular torsion. Testicular torsion, that's where you find the testis rotates around its cord. So when it rotates, it cuts off blood supply to the down part. And then you may be lucky and it unrotates itself, and then the pain goes off. You're like, I'm now okay. But it rotated. And it can rotate again if not treated. You get it? So any small pain, it could be a rotation, it could even be an infection down there. Otitis.
Yeah, men don't like treating infections.
Otitis, the scrotum is swollen, but you're there still debating whether to go to hospital or not. Yes. So any pain shouldn't be ignored in a man, especially if it is in the scrotum. Any discharge from the urethra, from the penis, the urethra, especially if it is a past discharge for a man, that is an emergency. Get it treated.
Okay.
Yes.
Okay. Our time has moved quite so fast. I know we have learned so much. We'll ask the doctor to leave us with his contact one more time. In case you need anything, you can call, and doctor, you can give them your contact.
It is on 078 57 43 055.
Okay. That is all we had for you today on the diagnosis, and we'll catch you next week. Stay watching Rest TV and be blessed.